scourge of this time, the mobile electronics, we began to see young generations that suffering from cervical disc prolapse, 20 and 25, 30 years old. So if you are going to do ACDF in a young generation, after 10 years, you might face adjacent segment degeneration or symptomatic disease. In comparison with arthroplasty, this risk is a little bit lesser. They found that the prevalence of adjacent segment degeneration might reach more than 32% symptomatic disc degeneration in ACDF, especially in double levels, especially in the from 2 to 5 years. So we have to find another solution. As everything is progressing, we should find a new prosthesis. Actually, it's not new because they have used it many years ago. So our primary goal might be improved to maintain physiological motion, avoid bracing, avoid the hassle of graft pseudoarthrosis, and early functional recovery, and reduce adjacent disc degeneration. From the biomechanical point of view, degeneration happens because once you achieve ACDF, the range of motion in the proximal and distal segment increases above the normal range of motion. And that's why degeneration happened rapidly. This will not happen in all cases, but it might happen in about 30% of the cases according to the literature. Also, in young adults, the range of motion is much significantly more than as you go older. So why I make fixation so normal physiological mobility in a 20 or 30 years old male or female. In kinematic point of view, the mobility of the cervical spine, especially in flexion, it is coupled motion, not only in flexion extension, associated with translation about 2 millimeters. And that's why when you do an CDA, you will find that you will have mobility preserved. And one of the most important things that you will preserve the normal physiological range of motion in the proximal and distal level. I used this in about 10 years ago, but it was uniplanar, and that's why I used it about 5-6 times. I didn't continue, although no complication happened, but I don't comment. To avoid the appealing of thing to be trapped in complication of CDA, there are contraindications also to use cervical disc arthroplasty. Infection, osteoporosis, allergy to the metal, cervical instability with translation more than 3.5 or rotational difference, severe spondylosis, no need because there is significant spondylosis. The patient will gain no benefit from CDA. Also, deformity and significant kyphosis. Why we adopted this criteria? Because it is complication rate nearly equal or less than the ACDF, long-term durability, equal and better term of lasting relief, reduction incidence of adjacent disc disease, and easy implantation as if you're applying a normal cage. So is it the gold standard? For sure not, because we have limitations. The biggest limitation in my point of view for the price. Financial issue is number one. So I have some tips and tricks about the technique to make it safe and avoid any complication with expensive prostheses like this one. First of all, you have to confirm your dead AB and lateral position with the C-arm. Avoid double shadow of the facet or the pores. Keep the head in neutral lordotic position, nor kyphotic or hyperlordosis. Fix the head with a tab to avoid any change in this positioning. Mark the midline to apply your prosthesis in dead midline position. Casper pins avoid to be close to the end plate to avoid osteolysis later on. Avoid over distraction, especially the facet. End plate preparation is very important, especially the cartilage. Some types of prostheses need to preserve the cartilaginous end plate. Other, you have to preserve, impose the bony end plate. Avoid over excision of the posterior elements, uncinate process, uncinate facet, because this might affect, as here, if you remove, it might affect the mobility and the failure of the CDA. Large footprint with lowest height implant is preferable. Confirm the disc position post-operatively. I have 8 patients with 6 males, 2 females, the age from 20 to 43, single level in 5 and double level in 3. There was significant improvement actually in the neck disability index from 52 to 16 in the mean. My limitation in the study is the number and the short follow-up. This is a 35 male patient with brachialgia and numbness, grade 1 weakness in the elbow. The neck disability improved and the visual analog score. Here is the MRI with double level disc prolapse. And here is the post-operative. This, when I measure the angle between flexion and extension, about 30 degrees difference in preservation of motion, from 45 in extension to 9 degrees in flexion. Another female, 32, with hyperplasia for 2 years, failed all medical treatment with grade 4 weakness in the elbow, also improvement in the neck disability in the MVAS, 4.5 and 5.1. Sorry, I'm rapid for the time factor. Here, our about the literature, let's begin with the negative feedback. Only one paper I found that was a high rate of operation for the arthroplasty from Sweden. And I found that they use it in a larger scope with old age, about or more than 60s and 50s. So they face more revision. But with a systemic review from Dan Rue and Joachim, they found that the revision rate is 3.9, which in total is much lesser than the ACDF. A great literature review from Gournay, 10 years for up, in all the next studies I your patient, it was statistically superior in overall success outcome measure, neurological success rate, NDI, and neck pain score. Thank you very much.